Question 18. Which of the following is the most likely diagnosis? Pancreatitis, cholecystitis, ruptured AAA, duodenal ulcer. Okay, so this is a GI question. Very obviously a GI question. A 64-year-old man presents to ED with sudden onset epigastric pain radiating to the back. Epigastric pain radiating to the back should send off some red flags for things like pancreatitis. That could be ruptured AAA, peptic ulcer. Those are some of the big ones. Epigastric pain can even be an MI though, so don't rule that out. The pain began 6 hours ago while he was watching television as it progressively worsened. Describes pain as deep, severe, rated 9 out of 10, associated with mild nausea, no vomiting. This is all fluff. Like, we really don't need any of this. I would say the only thing we do know is, or do need to know, is the acuity. So 6 hours ago. Everything else is pretty unhelpful here. He has no history of alcohol use. He reports dark urine. Okay, dark urine can be interesting, with pale stools. That is definitely something. We'll come back to that. On review systems, denies chest pain, shortness of breath. Okay, so no chest pain, but still could be an MI. His medical history includes hypertension, hyperlipidemia, blah, blah, blah. This is all very bland, and I don't even want to like when I'm doing questions, but this is also because I've done thousands and thousands and thousands of questions. I don't even bother reading a lot of this. I skim very quickly, and like this is all, you just have to find the buzzwords. This is fluff. Temperature is helpful. Always check out the vitals. The vitals are always helpful. And blood pressure. We need to know that for sure. Abdominal exam shows distension, marked upper quadrant tenderness without rebound or guarding. Murphy's sign is equivocal. Okay, what can we rule out? Blood pressure, 104 over 68. You think your blood pressure is going to be normal if you're bleeding out inside your own body? No. Perforated duodenal ulcer. That's pretty much the same thing. In 6 hours, it's not going to be as severe as a ruptured AAA, but you might still have some hypotension. You would probably also have a history of peptic ulcer disease or risk factors. They usually tell you something about it. So this is a little lower on my list. Mesenteric ischemia tends to present with a fever once necrosis sets in. We're mildly febrile, but not to what I would expect. But still, I'm still not going to rule it out because of that alone. Mesenteric ischemia typically takes place a little more inferiorly in the abdomen. I would expect maybe splenic flexure because it's a watershed. So this is also going to be a little lower on my list just because it's not quite the right place, and the vitals, it just doesn't check the boxes for me. Like, why is there back pain with mesenteric ischemia? You wouldn't expect that. Cholecystitis, pancreatitis. How do we tell the difference here? Okay, so can acute pancreatitis cause back pain? Absolutely. Can cholecystitis cause back pain? Maybe. Not really sure. What about pale stools, dark urine? Can acute pancreatitis cause pale stools and dark urine? No. So it gets an X. What about cholecystitis? Can it cause that? Also, no. But maybe we're thinking about that clue incorrectly. What if it's the dark urine and pale stools that caused either the pancreatitis or the cholecystitis, right? Let's think about this. How do you get dark urine and pale stools? Well, pale stools get their color from bilirubin. So if the stools are pale, that means they don't have enough bilirubin in them, and usually gets rerouted into the urine, hence why the urine is dark. So maybe this tells us that there's something preventing bilirubin from entering the stools. Bilirubin travels through the biliary tree, so we now know that there's got to be something obstructing the biliary tree. Okay, so let's say right here we got bilirubin, and it's trickling its way down here all the way into, this is the ambula vater, and then we have our small intestine, our duodenum here. Okay, but what if we plugged it up right here? Okay, so now we've got something in the way here. Now bilirubin's not going to make it into the stool, so we could get our pale stool, dark urine. Great. Would that cause pancreatitis? Here? No. Would it cause cholecystitis? Also, probably not. Cholecystitis is its own problem. It's when stone obstructs the cystic duct, right? If this is the CD, our cystic duct here, this would be cholecystitis, when there is a stone preventing things from flowing out of the cystic duct. But what if we had an actual cholecystitis, something blocking the cystic duct? Would that prevent bilirubin from reaching the small intestine? No, it wouldn't, because bilirubin, again, is made in the liver, which is up here. It's got nothing to do with the gallbladder. That just stores our bile, right? It doesn't actually make it. So cholecystitis wouldn't explain the pale stools, the lack of bilirubin making it to the GI tract. So let's flip the script here. What if our blockage was right here? Well, now got all this bile trickling down, and then it gets stuck, and it accumulates and accumulates, and it starts working its way back, and now it's going down path of least resistance. It's in the pancreas, causes inflammation, and you have pancreatitis, right? It'll go all the way back up here too. You might see hepatitis, you might see some elevated AST, ALT. So while it's totally possible that you could have a concomitant cholecystitis, it's not going to cause the pale stools and dark urine, and it's not caused by the pale stools, dark urine. Again, we were thinking about this one wrong. Acute pancreatitis checks the box for that one. Cholecystitis doesn't. Correct answer is A.